As we all know as haematologists, TTP is a haematological emergency, and we mustn't forget that in any patient who presents with fragmentation hemolysis and thrombocytopenia where there's not a clear underlying cause, we must assume it's TTP and start plasma exchange urgently. But if we go back to first principles, then we think about pathogenesis and what we've learnt from basic research in the last few years. And my talk highlighted the important work that's been done on the autoantibodies themselves. And there's increasing data now that actually, although we think of TTP as a disease of autoantibodies that are inhibiting ADAMTS13, a substantial proportion of patients have antibodies that are actually non-inhibitory. So if they're not inhibiting ADAMTS13, how are they causing TTP? And there's now nice data out there that shows that ADAMTS13 antigen levels, the actual amount of enzyme that we can measure in patients at presentation of TTP, is greatly reduced, with most patients at presentation having low levels of ADAMTS13 antigen, and in some cases actually less than 10% or so, sufficient to cause the phenotype of TTP without needing to invoke inhibition as a mechanism. And another important recent finding, published parallel papers in PNS a few years ago, is that ADAMTS13, the enzyme itself, can exist in both an open and closed conformation. This has probably evolved, the closed conformation, to give the enzyme its specificity. So ADAMTS13 cleaves VWF, it doesn't cleave other substrates. But when it binds VWF, the C-terminal domains binds, it opens up the enzyme, and it reveals not only other VWF binding sites, but what to the host immune system may represent cryptic epitopes. So therefore, potentially, partly explaining why we have ADAMTS13 as an autoantigen. So if we take then what we know about and learned about pathogenesis and think about how we can improve treatment for patients. So we need better prognostic factors in TTP. So even with treatment, it's an extremely serious condition with a 10 to 20% mortality rate. And up until now, we've not really had the ability to determine accurately which patients are likely to do better and which patients are at higher risk of death. So we're very fortunate in the UK, we have the UK TTP registry. It's the largest international registry of this incredibly rare condition in the world. And using data from the TTP registry, our group published in Blood last year on some of the prognostic factors that are important in TTP. So the antibody itself is important. The amount of anti-ADAMTS13 IgG that is present at presentation has a prognostic significance. And patients who died had a much higher level of anti-ADAMTS IgG at presentation than those who survived. Also, we've talked about antigen in terms of the pathogenesis of the disorder, but actually it has prognostic significance as well. And patients who died had a lower ADAMTS13 antigen at presentation than those who survived. And this is a large cohort. This is over 300 episodes of acute acquired TTP from the UK TTP registry. And actually the patients that did worse, that had actually an overall more than 1 in 4 risk of dying, were patients who had the highest level of antibodies in the highest quartile and who had the lowest levels of antigen. And it's not only the lab markers that are important prognostically, the same data set was used to look at the clinical features. And having cardiac involvement, even if it's just with a troponin marginally elevated above the local normal range, is a significant risk factor for mortality. And equally, having neurological involvement at presentation. So if your GCS is reduced even by 1 point, even if it's just because of intermittent confusion, giving you a GCS of 14, that has up to 9-fold increase risk of mortality. So that's the aspect of prognostic factors. How can we translate that into better care for our patients? So thinking about modern TTP management. So if we go back to the pathophysiology and think about what we're trying to do when we treat TTP, it's really threefold. We're trying to replace the ADAMTS13, which we currently do with plasma exchange. We're trying to clear the antibody, which we do with steroids and anti-CD20 therapy with rituximab. But there's actually a novel treatment strategy that's emerging for adjunctive therapy in TTP, trying to actually prevent the formation of those microthrombi. And so what my talk touched on was the data around caplacizumab, which is an anti-VWF nanobody. So it binds VWF and prevents the binding to platelets. The phase 2 data was published in the New England Journal a couple of years ago, showing that patients who had caplacizumab, in addition to standard of care, recovered their platelet counts sooner, and there didn't appear to be a strong bleeding signal. And what I also highlighted in my talk was the data that's been headline data from the phase 3 study, from the Hercules trial, that's been also discussed as an oral abstract this morning by my colleague, Professor Scully, showing that caplacizumab, in addition to standard of care, leads to a 1.5-fold increase in the rate of platelet normalization, and patients doing better in terms of overall mortality and thrombotic events without a significant bleeding signal. So this is an adjunctive therapy. We still need to clear the underlying autoantibody, because otherwise when we stop caplacizumab, the patients will relapse. But actually this potentially offers a novel therapy that can hopefully keep our patients safe while we're trying to treat the underlying autoimmune condition.